Hello class, and welcome back to our lecture on the vertebral column. And today what we're going to do is talk about the articulations between the vertebrae and the ligaments that are holding the vertebrae together. So that's really what this section is all about. So we'll take a look at some of the different joints, those that occur between the vertebral bodies, the symphysis joints, and then we'll also have the facet joints that occur between the articular processes of the arches. We'll also introduce a couple of special joints, one that occur between the atlas and the axis, and then another one that occurs between the atlas and the occipital condyles. Then we'll talk about the ribs attachments, so the costovertebral joints are where the ribs are attached to the vertebral column. And last but not least, we'll talk about the sacroiliac joint and where the sacrum is connected to the pelvic girdle. Along with that, we'll talk about the ligaments that hold these joints together and then bind basically the vertebral column into its long segment. So let's start with the symphysis joints, and of course these are the joints that are occurring between two vertebrae adjacent to each other. So you should notice that between the bodies we of course have those intervertebral discs there, and if you'll notice between the discs there is a layer of hyaline cartilage here that is sitting right on top of that bone. So that whole thing then is going to make up the intervertebral joint. Just a reminder, we talked about this in lecture, but it's worth remembering that the intervertebral discs do make up a quarter of your vertebral column's length. So they do add a considerable amount to your overall height, which can decrease as we age. And of course, do notice that most of the bones do have an intervertebral disc, but there are some exceptions. So between C1 and C2, there is no disc. And then from below the first sacral vertebra, all the vertebrae are fused together. So you'll find the inferiormost disc there at L5 to the S1 vertebrae. So at that level. This is showing us a nice section of a symphysis joint where we can see the bodies. So there's the body of the superior joint, and you see the body of the inferior joint right there. And you can see that we have this nice layer of the epiphyseal plate occurring on the end there. And you can see that we have a nice thin layer of hyaline cartilage right where the disc is. Do notice that when we look at the plates that will have that hyaline cartilage, that's that part that I just pointed out there and at the edge of the bone. This is what I call the cartilaginous end plate if you'd like, or just the hyaline cartilage plate. Then in between those two plates we'll have that epiphyseal or the intervertebral disc rather. Do notice that the intervertebral disc itself is fibrocartilage, and the center of it is rather that nucleus pulposus, that soft gelatinous portion. The fibrocartilage part is what we call an annulus fibrosus. So it's this kind of annular ring. If you can imagine from a top view down, it would be on the outside like this. And then what we're looking at here are these sections of the annulus fibrosus. One important thing to keep in mind is that in the center of this, we have the nucleus pulposus. This is a gelatinous core, and that allows us to give us some cushion to our vertebral column. Kind of like if you ever seen those or the Air Jordans that have the little cushion, the air pocket in the middle. Think of the nucleus pulposus like that. So as the vertebral column compresses down, these guys can give a little bit of cushioning. One thing I want you to appreciate when we're looking at this is that the anterior side is over here and the posterior side is back here. And what you'll notice from this view is that the anterior side of the annulus fibrosus is much, much thicker. So if you're going to have a herniation of the intervertebral disc, as you can imagine, this nucleus pulposus is more likely going to go posteriorly back here, and that's when it can then compress a spinal nerve, and that can give you that pain associated with a herniated disc. So it's not the disc itself that's really hurting, it's that pinched nerve that gets compressed. So this is just showing us a nice clinical application where we have the herniation of the nucleus pulposus, a soft gelatinous center, where it starts to either push the annulus fibrosus out, like we see here, or in some cases it might push through the annulus fibrosus and then compress that nerve. A lot of people will have a herniated disc, they won't even know it because unless it's pinching on that nerve, then it's not going to cause any symptoms, so it might just be asymptomatic. Do you notice that when it does cause pain, it can cause this acute pain that's coming from the pressure on the ligaments and also inflammation of that tissue at that joint, or at that nerve rather. So we'll be secreting different inflammatory chemicals, and that then can irritate the nerve, and that can also cause that pain. There's also, of course, can be chronic pain, long-term pain, and that can be resulting from the compression of the root itself. A lot of times this pain might radiate outwards towards the dermis, so you might think about the dermatome of the area that's being supplied, because it may not be the skin itself, it might be that underlying nerve that's kind of referred pain out towards that area. So referred pain, if you guys recall, is where you feel pain in one area, but it's actually occurring somewhere else. And this is a very common thing that we'll see throughout the clinics and throughout anatomy. Another thing to keep in mind is when we talk about what nerve is being compressed, we can have the nerve typically that's going below the disc. So I want you to appreciate here on this picture, this is the L4 vertebral body. And if you recall, the L4 nerve is going to come out from below that body in that intervertebral foramen. And here you'll see the L4 nerve root. But you'll notice that it's actually being spared. It's coming out from above that disc bulge. So it's not going to be the L4 nerve that gets compressed. It's actually going to be the L5 nerve, the nerve below that vertebral body, that's getting impinged by that disc. So I mentioned this in lecture, but of course a common symptom that we see is often with sciatica, and that's typically caused by a compression of either the L5 or the S1 component of the sciatic nerve. It will have multiple components when we get to the sacral plexus later on, but it's usually this one of those two nerves that gets compressed. So like I mentioned, it's going to herniation of the disc will usually affect the nerve root one level inferior to the disc, so not at that level itself, but the one below it. And do keep in mind, especially with osteoarthritis, when the bones start to get irritated, we can have those bone spurs starting to form, those osteophytes, and that can then exacerbate a compressed nerve. So this was one of those things I had in lecture, but since I'm doing this on the computer, we can just do it here. 29-year-old female elite athlete was lifting heavy weights during an intense training session. The athlete felt severe pain radiate suddenly to the posterior aspect of her right thigh and her right leg. So we'll consider this when we talk about the nerves that are going to the lower limbs as well, that are supplying them. And we get an MRI at the hospital, and now you want to see which nerve was probably most affected. So this is a very common question. Something like this you might see in an exam, whether it's one of my exams or whether it's the PANCE. You got to know what level you're at. And so what we're trying to do is we're trying to figure out where are we at along this vertebral column. Now, if you recall, the way to tell at this level is best by the angle between the L5 vertebra and the first sacral vertebra, the S1. So you should remember that L5 right here is going to make that that angle here with S1. So now we know what level we're at. And you'll notice that the compression of the nerve, the intervertebral disc, is actually up here. So here is the L4 vertebral body, but notice this is the intervertebral disc, there's the IV disc, that's between the L4 and L5 vertebra. So I'm hoping you guys are starting to think, well, it's obviously not going to be the second lumbar nerve because that would be above these. And I want you to really start thinking, okay, it's right at this intervertebral disc between the L4 and L5. Will it be the L4 nerve? No. Because if you recall, the L4 nerve, if we look at this picture here, that actually gets spared at that intervertebral disc, or by that intervertebral disc. So it's actually, even though it's at that level, this is going to come out above that disc. So it won't be that either, right? It's coming out at that intervertebral foramen below L4, but the disc is actually below that intervertebral foramen. So that's where things can get a little bit tricky. So hopefully we can understand it's definitely not L3 either because that's above the impinged disc. And hopefully we can understand it's not going to be at S1. So of course L5 should be the nerve that gets compressed at this level. So you do want to get comfortable with learning how to read these MRI images and understanding where a disc can affect a nerve at what level. So hopefully that kind of helps us think these things through. This will be true with the cervical vertebrae and the cervical nerves too. I'll talk about that later on, but cervical nerves, even though they come out from above that vertebrae, the nerve that actually gets compressed is going to be the one below that intervertebral disc. So this will be true across the board. All right, so here we have a, just want to throw that out there. You can have a MRI, so this is showing us without contrast. A lot of times it might be useful to add contrast, and contrast will help us see different images in different views, and you can kind of see these show up nice with that disc herniation. All right, so now that we've talked about the bodies, let's talk about how the bodies are joined together in the intervertebral disc. On the front of the body, you'll notice this big, thick ligament that goes all the way down the front of the bodies. And this is called the anterior longitudinal ligament. Notice it's covering the vertebral bodies and the intervertebral disc. It's one big ligament, pretty much going the entire length of the vertebral column. So it's going to go all the way from the C1 down to the sacrum and even down to the occipital bone on the anterior side of the foramen magnum. So that'll be all the way through the front. Do you remember this stabilizes during an extension? So when you're extending, this is going to help stabilize the vertebral column. If you guys remember when we hyperextended, let's say you get hyperextension, you can often have that torn in like a whiplash, right? So this can be torn in whiplash as that neck goes beyond what this ligament can actually hold on to. Notice behind the bodies, so this is where it gets a little bit confusing, but this is actually behind the bodies, but we're actually in front of the vertebral canal. So this is the vertebral canal right here. There is a much thinner ligament that goes the length of the vertebral canal. This is the posterior longitudinal ligament. Because it's actually within the canal, it's not outside of it, it's going to be much thinner, much narrower, and much weaker than the anterior longitudinal ligament. And it will have areas where it starts to kind of come out laterally in between the pedicles. So these are the pedicles that are sticking up. And you're going to see this kind of stabilizing the vertebral bodies from the back. So this is within the vertebral canal on the posterior aspect. And this is going to go pretty much from the second sacral or second cervical vertebrae all the way down to the sacrum. So almost all the way, not quite up to the foramen magnum like we saw with the anterior longitudinal ligament, but it will be back in the posterior side. So this is going to actually provide stabilization during flexion. So as you flex the vertebral canal, you can imagine these ligaments being stretched, and that's going to provide us with that support and that stabilization. One important thing to keep in mind is that this can, because it's on the back of the intervertebral disc right here, it can help provide support and prevent that herniation of the nucleus pulposus. It kind of holds that nucleus pulposus within there. If it does get inflamed, if you do have a herniated disc though, it may be partially this that can have a nerve ending that can supply pain. So it doesn't have to be the spinal nerves themselves. It can actually be any of these connective tissues, whether it's the periosteum, whether it's the ligaments, because ligaments will have pain receptors in them. We often call this nociceptive pain when we talk about this kind of internal pain, if you would. Our next joint will be the Zygapophyseal joints, the facet joints. And these are plain joints. You can see it is a true synovial joint. So there is a thin layer of articular cartilage that'll have synovial fluid in there. So we have a joint space right there. And they'll have a joint capsule. So these would be classified as a gliding or a plain joint, if you'd like. So gliding joint. And just a reminder that these are going to be between the superior articular process and the inferior articular processes of above and below. And we use that term facet whenever we talk about the edge of that joint, but process works just fine. So when we think about the orientation, do you remember that the orientation, like we've mentioned in our last lecture, it will determine the range of motion. So cervical, as you can see back here, they're kind of going straight up and down. They're a little oblique, but they're going to be a lot of superior, inferior, if you would. Whereas the thoracic later on, in fact, you can kind of see C7 is actually going to be a little more facing downwards than these guys. So I put this just a kind of reminder of how these are oriented. Cervical, we often use this acronym BUM, backwards, upwards, and medial. It's mostly upwards and a little bit backwards. And you can see right here how that orientation is. But it's kind of almost flat like this, but just slightly tilted a little bit. Actually, backwards would be more like that. So That's where the cervical is. And that's going to allow for a lot of that motion, that rotation that you have in the neck. In the thoracic area, I mentioned this in lecture, but it's worth recalling. These guys are going to be primarily anterior, posterior. So they're going to be forward and backwards, almost kind of vertical. So backwards, if you like, upwards, and a little bit lateral, but I just like to say anterior, posterior. That's usually the easiest way to remember. The lumbar, these guys will wrap around each other. So you're going to see there's this kind of lateral facing and the medial facing. So here's the superior articular process kind of facing medially as it faces inwards. There's the inferior articular process facing kind of laterally. So these guys are going to be really locked in together to prevent a lot of that rotation of the lower back. But they will still, of course, allow for some flexion and extension. So this just reminds us of adjacent articular processes. Inferior is actually going to be the one above, and the superior is going to be the one below. So what I mean here in this is that this is the inferior articular process here, and the one below that is actually the superior articular process of the T11 vertebrae, as you can see. So do keep in mind that the superior articular process is going upwards, but it's actually going to be forming the foramen of this area right here below the body of the adjacent vertebrae. Sometimes the naming can be a little tricky there, but I do just like to keep that in mind. And once again, we like to think about the orientation, which was pretty much covered, and the range of motion as well. Do keep in mind that these zygapophyseal joints do have innervation, so they can get irritated. They can provide pain as well and proprioception. And so we're going to have these branches, these nerves, that are going to be coming off what we call the articular branches coming off the spinal nerves. So you can kind of see as the spinal nerves are coming out. So here is the spinal nerve itself. Notice we're going to give rise to branches that'll go to the annulus fibrosus. So that'll also have some proprioception to it as well. But now you can see this right here is the posterior ramus. Coming off that posterior ramus, some of these guys are going to come back then and supply the facet joints. This is where things get interesting because the facet joints are the only part that we'll see here that's actually supplied by the posterior ramus. Everything else will be supplied by the anterior ramus. I think I go into a little more detail about that later on, but it'll be that posterior ramus that supplies those facet joints. So do notice that each joint is going to be supplied not just from the one there at that level, but also the one above it as well. So we have some fibers that are coming down, as you can see here, from above, and some fibers coming in from below. So we're going to get actually two nerve supplies there. All right, guys, this will bring us to our next, next ligament. So we've covered the anterior, the posterior longitudinal ligament. Now let's take a look at the ligamentum flava. So this is referring to this ligament right here that we can see right along the vertebral arches. And you can see this is going to be connecting the adjacent lamina of the vertebrae together. So if you guys remember when you do laminectomy, you take off that spinous process, this ligamentum flava will often come with it. So like I mentioned, the name is coming from that yellow color, and it is vertically oriented. So here we have the vertebral column going straight up and down. You can see these ligaments are going straight up and down. So they're vertically oriented. And they're going to limit flexion of the spine. So when you start to flex the spine, as you guys can imagine, this would basically stretch these ligaments, and they're going to resist that flexion as it begins to flex. So limitation of that. And that's good because the posterior longitudinal ligament didn't provide a whole lot. It's pretty weak. So this will provide some extra support. And another thing to keep in mind, this is going to help preserve the curvature of the spine and assist with straightening the vertebral column after you flex. So after you flex and you're trying to bring it back up in the upright position, these will kind of help that side-to-side motion, essentially, if you would, that you can get there. Now, one other set of ligaments we can see here are the intertransverse ligaments. Intertransverse, as you can imagine, go from one transverse process to the next. So here are these guys. And what these guys are doing is essentially providing this lateral stabilization from side-to-side movement. So if you were to move the vertebral column to one side, let's say this way, these ligaments here on this side they would stretch, and they would prevent that from happening. If you were to have lateral rotate or lateral movement going this way, then these intertransverse ligaments would stretch on this side. And so that's going to really prevent this kind of rocking movement, this back and forth, left and right movement of this vertebral column. Hoping that makes a little bit of sense how these guys really work together to keep all these vertebrae nice and supported. Now, in between the spines, we have our interspinous ligaments. So these are the ligaments here in between the spines, as you can imagine, holding the spines together. Fortunately, the name says it all. That's an easy way to remember. So between the spinous processes, they are more developed in the lower back, not so much in the cervical region. Hopefully that makes sense because we want to have more mobility in that neck so that we can move it around so it won't be quite as thick up there. And this will be most prominent during flexion because, as you can imagine, when you flex the vertebral column, these spines will want to come apart. This will prevent them from coming apart too far. Now, our next ligament, the one that we'll see on the very, very back of everything else, is this guy right here. This is the supraspinous ligament. So once again, as the name implies, supraspinous ligament is going to be riding right along the edges of these spines, just like that. So they're going to be going from the tips of one spine to the next, to the next, to the next. This is going to go all the way from C7, the vertebral prominence, remember your C7, all the way down to the sacrum. Once again, like the interspinous ligaments, these are going to limit the amount of flexion that you get during your movements. So that will work pretty much alongside those interspinous ligaments. Now, one important ligament I wanted to point out is the nuchal ligament. So you'll notice that the spines are pretty deep down here. If you've ever seen a skull and you appreciate on the skeleton that there's a big space there behind that neck. Well, that's because in life, you don't see that in life, right? Because the neck looks like it goes pretty much straight down. That's because we have the muscles and we have this nice thick nuchal ligament that's coming along the back of the neck. So this is going from the occipital protuberance. So you can see there the external occipital protuberance as it goes down to the seventh cervical vertebra here, the vertebral prominence. And you can see it's kind of attaching to that spine right there. So that's going to pretty much occupy the back of the neck. That is an expansion of the supraspinous ligaments where they got much thicker in this open area. And like the rest of it, it will limit flexion. All right, so there's our ligaments. Now let's take a look at some of our special joints. And the first ones that we'll look at are the craniovertebral joints, where the cranium is attached to the C1 and the C2 bones, the atlas and the axis. So up here, do remember that there is no disc between C1 and C2. So there's our C1 right there. There's our C2. And you can see that there are ligaments here that hold these guys together, but there's no intervertebral disc. So this is going to, of course, provide for a wider range of motion because a lot of that motion at the skull will come from the articulations either between the occipital condyles and C1 or between C1 and C2, about 50%. All right. So let's take a look first at the atlanto-occipital joints. And I mentioned this a little bit in lecture, but here it is again, so we'll go over it. But that's occurring right here. There's the occipital condyle of the skull, and that's articulating with C1, which is right down below it. So there's the posterior arch of the atlas. So these are condylar joints, which means we'll get flexion and extension, and we'll also get some lateral movements, some side-to-side flexion and extension, but there won't be rotation between these, right? Condylar joints don't really have a whole lot of rotation. It's pretty much the same joint that you'd find between your proximal phalanx and your metacarpal. Flexion and extension, side-to-side movement, but no rotation. So I would like to think of this as our yes joint because this is going to provide flexion and extension. So when you shake your head yes, about 50% of that movement will come from this joint. The other 50% will come from the rest of the cervical vertebrae all working together. You do get a little bit of that sideways movement with the tilting as well. So here's our next joint, the atlantoaxial joint. And here we can actually see we have three articulations. We have the two facet articulations where we have the superior and inferior articular facets. But then we also have this third articulation here is the pivot joint. So this is the median atlantoaxial joint. And you can see that transverse ligament going across the atlas, and is going to basically form this wrap around the dens or the odontoid process, and that's going to allow you to move your neck. No. Just like we saw with the atlanto-occipital joint, the atlanto-axial joint will provide about 50% of movement. In this case, it's going to provide rotation, whereas the other 50% are coming from your lower vertebrae in the neck. Very important you start thinking about the limited range of rotation or flexion, or if you have pain in this type of movement. So we start to think about how these joints are going to be affected. So this is just showing us the nice movement between the atlas and the axis, and you will see that the C1 will move with the cranium as a unit. So you can see as you turn your head to the left here, you're going to see the C1, there's our C1, that will move with the cranium, and same thing when you move to the right. So do keep in mind that the atlas is rotating along with the cranium. Keep that in mind when we start talking about these things clinically, especially. All right, guys, I just wanted to put out a couple of ligaments that are holding the C1 and C2 to the occipital bone here and to the cranium itself and holding them together. So there is one ligament coming right at the very top. You can see it here on the dens. This is C2. C1 is this guy right there. And as you see coming out from the top, there's this ligament called the apical ligament. So the apical ligament will actually connect the C2 vertebrae to the foramen magnum. So we do see that even though you rotate your neck back and forth, there is still some limitation from this ligament that's going to pretty much hold it in place so you don't over-rotate it. Other ligaments that we'll look at are what we call alar ligaments. Alar ligaments are going to be on each side of the apical ligament, and they're going to connect the odontoid process to the medial side of the occipital condyles. So you would have had the apical ligament. The apical ligament is kind of hidden back here. You don't see it very well. But then we're going to have these alar ligaments, and these alar ligaments are going to be pretty much going out from side like this, going out towards the occipital condyles. That would be those guys right there. As we look at this, we will next talk about these cruciate ligaments. Cruciate means cross. And the reason we call it a cruciate ligament is because it literally looks like a cross. It has these vertical fibers going up and down, lateral fibers going sideways, sideways. The superior cruciate ligament we can see right here is actually going to cover the apical ligament. So we don't see the apical ligament from this view. If we go back a slide, this little guy was the apical ligament, but then right behind it is going to be that superior cruciate ligament, which we can see right there. Going downwards from the dens, we have the inferior apical ligament, and that's going to go to the body of the axis coming down from that odontoid process. So that would be superior going up like this, inferior coming down to the body. As you look at the sideways view, then the sideways view, whoops, where was I? Here we go. Or not the sideways view, but the lateral part here like this, that's actually what's going to be forming that transverse ligament that we've seen. So where you get that rotation, that's the transverse ligament of the atlas. This is just a reminder of the different type of movements that we have at each area. So here we are in the cervical spine and the neck. So notice you can have that lateral flexion, get a side-to-side movement, flexion and extension, forward and back. And then, of course, you get rotation. Like I mentioned, that's primarily at the atlanto-axial joint, but you'll also have about 50% of it coming from your other cervical vertebrae as well. As we come down to the thoracic and lumbar spine, it's important to understand these guys are going to be moving kind of together, and they're going to provide different types of movement. So lateral flexion, when you have that side-to-side movement in the lower spine, that's primarily lumbar because remember the ribs are in the way, so they will limit the amount of that lateral flexion. You can also have flexion and extension, that forward and back, and then we can also have rotation. And rotation, as we can see here, is provided primarily by the thoracic vertebra. So just keep in mind where that rotation will occur. And that's the same thing. I must have duplicated that slide, so we'll skip past that. The next thing we want to think about are the different curvatures along the vertebral column. So here, if you have a nice plumb line, you're trying to make something nice and straight and vertical. Obviously, the vertebral column is not straight vertical. There are curvatures here. And if you're looking at it anteriorly, looking at it from the front here, you can see the thoracic area. Down here, it will concave vertically. This is what we call a kyphosis. A kyphosis is that concave anteriorly. You also get another one down here in the sacral region, so hopefully you can appreciate that both of these are kyphoses. We often use the term kyphosis as a disorder if it's hyperkyphosis, but kyphosis is really the name for a normal curvature as well. If it's convex anteriorly, so if it's coming out, let's say now you're looking at it from the back, this view here, so it'd be convex anteriorly or concave posteriorly, that would be called a lordosis. So there's a cervical lordosis, you can see here in the cervical spine, and then a lumbar lordosis down here in the lower back. So we get these two kyphoses, these kind of posterior curvatures in the thoracic area and the sacral area. And hopefully that makes sense, because what we're doing here is we're enlarging this space to make room for your thoracic organs. You got to be able to fit your lungs, and you got to fit your heart in there. And then down here in the sacral region, you got to be able to fit those pelvic organs, right? The urinary bladder, the uterus, and the descending colon and whatnot all have to fit in there. So that's really what these curvatures are doing. So this just shows us our cervical lordosis in the cervical area, thoracic kyphosis in the thoracic area, lumbar lordosis, and pelvic kyphosis. Now, the way these curvatures are developed, we want to think about how they're actually formed and what makes the curvatures, and we can see that there's two different types. We have the primary curvatures, and then we have secondary curvatures. The primary curvatures are going to be those that appear during fetal development. And you can kind of see, hopefully you can appreciate this kind of just C-shape like this. There are primary curvatures here, but no secondary curvatures. These are where the kyphoses form. So you can imagine when you're in that fetal position, you're developing all of this, you're going to have this thoracic kyphosis forming, and you'll also have that sacral kyphosis forming. The secondary curvatures, they won't develop until later on. They'll develop during infancy as the baby is starting to crawl around, starting to move around, starting to tilt their head up, look around, and then even start walking upright. So during infancy, when you start sitting upright, you start looking upright, then you'll start to develop that cervical curvature, that cervical lordosis, and the lumbar lordosis. So this is just showing us how we acquire these curvatures. Here we are in infancy. Notice you've got that primary curvature starting to form. As the baby begins to lift the head, you can start to see that cervical curvature forming right there. And then as we start to move around, you'll get the lumbar curvature forming as well. So lumbar lordosis, cervical lordosis, both being forming at these stages. Of course, we do want to keep in mind some abnormal curvatures, right? You guys are going to be seeing a lot of these. Probably, I guess it depends what you're doing, but definitely we want to keep in mind the abnormal curvatures. One of the big ones that we look for is, of course, scoliosis. So scoliosis is where we can see this abnormal curvature along that spine. You'll also notice that this might be accompanied by rotation of the vertebra, especially in the thoracic area. So some of those thoracic areas might get kind of rotated as you get that bending going on. And this, as we can see here, is most common in adolescence during periods of growth. So as you're starting to enlarge, starting to grow, go through puberty, you might start to see this. Now, most cases are idiopathic. That doesn't mean we're idiots about it. We just don't know what causes it, right? We just say we see it, it's being caused. We don't know why it's being caused, but maybe we can keep an eye on it. We can observe it and maybe even treat it if it's severe enough. So keep in mind, one of the ways that we measure scoliosis is what we call a Cobb angle, and the Cobb angle is going to be this angle off the deviation. So you can see here, you get this kind of deviation off the midline there, as you can kind of tell from scoliosis. So there is normal curvature side to side. Not everyone's perfect, so we do get some lateral deviations. We do not consider it scoliosis until it's really more than 10% of the curvature there. Or, I'm sorry, not 10%, 10 degrees deviation away. A lot of times it is asymptomatic. People have scoliosis, don't even have any symptoms of it, but you might have it discovered during physicals. I know in school they used to line everybody up and then have you lean forward. And usually what they're looking for the curvature of the spine, that Cobb angle. And then you can also tell because the erector spinae muscles typically tend to be higher on one side than the other. And that's another little way you can tell with scoliosis. Tend to be off balance. So when we think about the management of these different degrees of curvatures, then we like to think about the skeletal maturity. Is the skeleton still developed? Are we talking about a child, an adult, or someone else, about that age? And we want to think about the puberty status, right? So are they fully developed or are they still growing? Like I mentioned, if it's a Cobb angle that we're looking at, anywhere between 10 to 30 we consider to be mild scoliosis. So you can usually observe this and then have them come back 6 months later. Has there been an increase in that Cobb angle? If it goes beyond 30, then we consider it moderate scoliosis. And this is where you might have to have a brace, a thoracolumbo-sacral brace. I guess they had to put every segment of the vertebral column in there, except for the cervical area. But anyway, thoracolumbo-sacral brace might be indicated, so that should help eventually straighten the spine up. Like I mentioned, patient's compliance is always a big concern, and so sometimes having people wear these braces when they need to, going to school, you might need to encourage them to follow those guidelines, those indications. If it's severe, it's over 40 degrees, we do consider it severe scoliosis, and this may require surgery. So there might need to be some correction if it's over 40 degrees. So here you can see a nice 60-degree scoliosis, pretty severe. And over here, 42 degrees, just over 40. It's about the upper limit of what we would consider a moderate scoliosis. Other curvatures we want to think about is kyphosis. As I mentioned before, kyphosis is a normal curvature. So with this, we sometimes will say hyperkyphosis, but usually we just shorten it to kyphosis. And you'll often see this is going to be due to this increase in the thoracic curvature. And as we age, what will happen is the bodies down here will start to degenerate, and they'll start to cause this kind of increase on the anterior side and give us what we call the Dowager hump. That's what we like to think of as that hunchback back there. So, as I mentioned, this is resulting from the erosion of the anterior part of the vertebra, and that's going to cause an overall loss in height. One big thing to keep in mind with things like kyphosis is as we have that anterior curvature, you're actually going to decrease the pulmonary capacity. You can imagine the lungs in this condition, when it's pathological like this, won't have as much space to inflate or to expand. So you will have an increase in the anterior-posterior diameter because you're going to have this leaning forward, and then that's going to affect perhaps breathing if it becomes too severe. So just a little bit about kyphosis. Here we see kyphosis. Once again, we do want to keep in mind our normal Cobb angles, and we do have that natural kyphosis here. Typically, somewhere between 45 to 50, that would be considered normal. If it goes beyond 45 to 50, then we have to start thinking about the hyperkyphosis. How can we treat that, right? And there are ways to treat hyperkyphosis. So if it's mild to moderate, maybe you have a Cobb angle of 50, Cobb angle to 70. Physical therapy is a good way, right? You go to a physical therapist, they'll teach you some exercises, some ways to help treat this, to help alleviate this, to help manage it. And if it's over 70, it might be severe, and it may actually require surgery, depending on the complications it can provide. Here's our lordosis. Lordosis is excess lumbar curvature. So you can see here, very common if you're pregnant. So we can see during pregnancy, we often have this extra weight on this belly from the developing baby, and that can provide this lordosis as well. So you're going to see this kind of excess rotation of the pelvis as well. And with obesity is another big factor. So pregnancy, obesity, anything that might weaken those trunk muscles that can kind of help keep the vertebral column upright. All right, guys, so there's just our different curvatures. Scoliosis is that lateral bend. Kyphosis is that excess concave, looking at it from the front, that kind of Dowger's hump, if you would. And then lordosis, we have the accentuated convex if you were looking at it from the front, or concave if you're looking at it from the back, however you like to describe your angles. All right, guys, now we want to think about the arteries that supply the vertebral column. So we'll just knock these out real quick. And they are important because, of course, if you have loss of blood flow to any of these, they can affect the bone health. So what we'll see is at each segment, we have these segmental arteries. And these segmental arteries are going to arise from different regions, depending on where you're at. If you're in the neck area, you're going to see the vertebral arteries. You remember going through the transverse foramen. As they go up, they're going to give rise to arteries that will then serve that cervical region, and that will provide the bone. There are other arteries which we will talk more about with the muscles and with the nervous system. The ascending cervical arteries, which we will get to later on, but they will go up as they start to ascend, as the name implies. They're off branches to the bones as well. In the thoracic region, we're going to have these posterior intercostal arteries, and we'll talk all about these guys later on. But you can see these guys right here, the posterior costal arteries, are going to be riding right around the ribs. So when we take a look at the ribs, and we take a look at the intercostal arteries, these guys, not all the way in the front, but towards the back part, they will be supplying not just the ribs, but they'll also be supplying that vertebral level as well. In the lumbar area, we will have a couple of important arteries. The subcostal. Subcostal is weird because you want to call it an intercostal, but because we're at the 12th rib, we actually call it subcostal because it's below the inferiormost rib. There's nothing below it. So that's the name for the fancy name for that segmental artery at the 12th rib. So the same thing as the intercostals, it's just at rib 12, and it gets its own name. And hopefully we'll identify that in our lab. Then down in the lumbar area, you can see that we have these segments of lumbar arteries coming off, usually about 4 to 5 of these guys coming off. And you can see those lumbar arteries will supply that lumbar part of the spinal cord. No, I'm sorry, not spinal cord, but vertebral column. They will get the spinal cord too, but we'll talk about that with the nervous system. Last but not least, as you get to the sacro region, the iliolumbar arteries are these special arteries coming off right here. As the name implies, coming from the lumbar area of the vertebra and the ilium, and then the median and sacral artery. Median sacral artery is going to come right down towards the middle. As you can imagine, it's one artery going straight up and down. There it is right there. And then just off to the side, we'll have these lateral sacral arteries. So we'll identify a lot of these as we continue our dissection. So I thought I'd at least introduce them early on in the course. So hopefully as we get more and more exposure to them, you guys will become more and more comfortable with their distributions and what they serve. Now, as we look at the vertebral body itself, we can see, so some of these segmental arteries are coming off the aorta. So there's our abdominal aorta. And then depending on what segment we're at, the distribution is very similar along the entire vertebral column. The point is, coming off of each segment, so let's say, for example, here's a lumbar artery, right? So we're in the lumbar region. And if we go back, that would have been one of these guys coming out from right about there. And we follow its pathway to the vertebral body. You can see it's giving rise to a couple of branches. The equatorial branch, as the name implies, think of like the equator. The equator is going to wrap around the globe. Well, guess what? The equatorial branch is going to wrap around the body of the vertebra, just like that. And that's going to be supplying the vertebral body. So this branch coming around that vertebral body is an equatorial branch. As it's coming out, it's going to throw off little twigs. These twigs are called periosteal branches. Periosteal branches, as the name implies, supply the periosteum. So that's coming off of the aorta right there, those equatorial branches along with the periosteal branches. All of this pretty much to supply the periosteum of the bone and the bodies of the vertebra. Now, as you go towards the back, because we need to take care of all this stuff too, right? We need to take care of the pedicles, the transverse processes, the spinous process. Well, the back of this is going to be supplied by a couple of different arteries here. One of the big ones is the anterior vertebral canal artery, or the anterior vertebral canal branch, and that's coming off the equatorial artery back here. So here is our, I'm sorry, not the equatorial artery, but the segmental artery. So here's our segmental artery, the lumbar artery. You can see it's going to continue here, And as it gets towards the vertebral canal, it's going to fork. It's going to branch. One branch goes inwards towards the vertebral canal. That's going to form that anterior vertebral canal artery. And as we can see here, guys, this is going to come in and it's going to form nutrient arteries. If you guys remember, a nutrient artery is what actually supplies the bone. And so that's supplying the bone to the bone marrow. So it becomes very important when we talk about metastasis of cancers once again, but when we think about spreading bone to bone, a lot of these arteries, a lot of these veins can provide different pathways. So that's the anterior segment of that spinal branch, that coming back here from that segmental artery. Notice the posterior branch is going to come back here. And the posterior branch, I'm sorry, not the posterior branch. This posterior branch, we're going to be going right here. That was the continuation of the lumbar. That's my bad. The posterior branch, which we see here, is going to the back of the vertebral column. And one of the important nerve or things that will give rise to is what we call radicular arteries. Radicular arteries supplying radicular or the nerve roots. You guys may hear of radicular pain. We're talking about spinal pain coming from the spinal nerves. Well, there's that artery that will be supplying those nerve roots. So hopefully you guys can think of these radicular arteries that are going back to supply the nerve roots. And last but not least, we'll have the segmental medullary artery. We'll talk more about this with the spinal cord itself, but the segmental medullary artery, that's going to be supplying the spinal cord. And actually the spinal cord gets its blood supply from a few different areas, but this would be one of the ones coming off the segmental arteries. All right, guys. I just want to remind you that all these arteries, these segmental arteries, so that's the lumbar artery if you're in the lumbar area, the intercostal arteries if you're in the thoracic area, the cervical arteries in the cervical area, that's kind of the term that we use for these segmental arteries, depending on where you're at. But I just want to mention that they are forming these anastomoses. So we can see these kind of vertical connections here at different levels. So if you have one blood supply lost in one part, you can still have a continuation somewhere else. So just remember that these are all interconnected. As for the venous drainage, I did mention this in our first lecture, but it's worth, or maybe it was last week. Anyway, it is worth going over for a little bit here. The big vein here coming out from the body is what we call the basovertebral vein. And you can, of course, see here that it's going to be draining the blood out from that red bone marrow. So that's going to be pretty much taking the blood outwards. As it does come outwards, it will go to these spinal veins. And these spinal veins are all interconnected, forming these what we call plexuses. The internal venous plexus, we can see right here within the vertebral canal. That'll play an important part when we get to the spinal cord. We mentioned it a little bit, but we'll talk about that later on. Then outside, you'll have the posterior vertebral plexus. Once again, this is on both the posterior and the anterior side. It's basically everything outside that vertebral canal, though. Do keep in mind that as we're receiving this blood through these plexuses, we will have these intervertebral veins. Intervertebral veins are going to receive the blood from those venous plexuses. So these guys will drain into those intervertebral veins that are coming around from the side. And then eventually, these guys will eventually drain into the vertebral veins of the neck, which we'll get to later on, and the segmental veins of the trunk. And the segmental veins pretty much follow the segmental arteries. Vertebral veins in the neck, intercostal veins in the thoracic area, lumbar veins in the lumbar area, so on, so on. So we'll get to those. But the vertebral veins, those are the same ones that go with the vertebral arteries. All right. Last but not least, we also want to think about the nerve contribution to the not the meninges, but the connective tissue, because a lot of your pain fibers will be coming from these nerves. So here's where we talked a little bit about the nerve distribution. Here's your ventral roots coming out, and here's the dorsal roots coming out. And then you're going to have the spinal nerve forming from where these guys come together. Do notice that the intervertebral disc, along with all of the ligaments, these are all going to be served by the ventral rami. Remember ventral rami? Those are going to be the guys coming off front. So here it is, also called the anterior ramus. What will happen is this guy will throw off fibers, and it'll come back and supply some of these connective tissues, these ligamentum flavum, the bodies, and whatnot. The posterior aspect, the vertebral arch part, that's going to be supplied primarily by the posterior ramus. So here we have our posterior ramus right there. That's going to come back and supply the transverse processes, the lamina, the spinous process. So hopefully it makes sense. Anterior goes anterior, posterior goes posterior. Now, some of the special nerves that we'll be thinking about, and this will become important when we talk about the nerves or the spinal cord itself. We will have what we call the meningeal nerves, or simply recurrent meningeal nerves. Recurrent means that it's going to go backwards, right? And all that means is as we come out here the two roots come together, they form the spinal nerve. Here we leave the intervertebral foramen, but guess what? As we come out, some of these guys will kind of backtrack. They will go back this way. That is going to form a recurrent meningeal nerve. Usually we just shorten it to meningeal nerve. Do you notice that these recurrent meningeal nerves, they serve pretty much everything. They serve the bodies, the intervertebral disc. They'll serve the major ligaments, the ligamentum flavum, the anterior longitudinal ligament, the posterior longitudinal ligament, and the blood vessels themselves, right? The vasoconstriction, vasodilation. The posterior rami, these are special because they will serve specifically the facet joints. So here we have the facet joints, and they're going to get a very unique distribution. Those are going to specifically come from the posterior ramus. And that's kind of a unique area there where that's what they're really serving. All right, guys, just a couple things about clinical correlations for the back pain. You guys are going to see a lot of it. Second most reason people visit their doctors is due to back pain. You got to figure out, all right, is it muscle pain? Is it ligament pain? Is it tendon pain? Is it bone pain? Is it nerve pain? Is it from a compressed nerve, right? So I put this up here just to kind of remind us some of the major sources of pain, where you're getting it from and how it can be affected. One thing to think about, the fibroskeletal structures. These would be the major ligaments, the periosteum. Remember, the periosteum will have nerve fibers, the ligaments will have nerve fibers, the annulus fibrosus will have nerve fibers. The bone itself, however, does not have nerve fibers, or it's very lightly sensitive. So most time bone or back pain is not going to be coming from the bone itself, but rather these ligaments being overstretched, being strained or sprained. You can also have pain coming from the meninges. So we'll talk about the meninges with the spinal cord. But here you can see the dura mater, the arachnoid mater. These guys can have pain fibers that would be associated with it as well. The synovial joints, those are important because when we think about the zygapophyseal joints, the facet joints, those are going to be supplied by the posterior ramus. So you can imagine if you have a posterior ramus back here, supplying one of those joints, hopefully this will help us localize where that pain is coming from. Then also think about the back muscles, right? Specifically the intrinsic muscles of the back. The intrinsic ones are those that are holding the vertebral column upright. If the pain occurs, when you're moving, that might be the extrinsic back muscle, not necessarily back pain. But when you're thinking about actually the lower back, the erector spinae muscles, those are the intrinsic muscles, definitely a source of back pain. And that's oftentimes referred pain as well. And then, of course, the nervous tissue itself can cause pain, whether the spinal nerve is compressed or the dorsal root is compressed or maybe inflamed. It doesn't have to be compressed. It can just be irritated. That can also cause that pain as well. Or maybe it's been overstretched. So that should cover our lecture on the vertebral column. So next time we meet, we'll continue our discussion and we'll move along, talk about the back muscles. I'll see you in the next one.